Okay, guys, this is Mubin. We're talking about the cardiovascular system general principles. The lecture today is about various pressures and the factors that affect the pressures. This is physiology, not pathology, so we'll not be talking about the diseases in it. So before we do the lecture, let us just understand a few concepts that we are going to use here. First of all, what is a stroke volume? Stroke volume is the amount of blood ejected through a ventricle during the systole. The formula is end diastolic volume, that is the total volume in the ventricle before it squeezes, minus end systolic volume, that is the amount of blood left in the ventricle after it has squeezed or ejected the blood. So let's say if the ventricle had 150 milliliter before it contracted, then after contraction the amount of blood left is 100 milliliter, then of course that means 50 milliliter was ejected. That is called the stroke volume. Of course these numbers are more pathological than normal. Now total peripheral resistance. Total peripheral resistance is the total resistance offered by the systemic arteries. That resistance is responsible to maintain diastolic blood pressure. We'll talk about it. However, the thing that as a student, as a doctor, you must know is that the total peripheral resistance, the major contributor to that is arterioles. If you look at it, aorta has the mean arterial pressure of 100 millimeter of mercury. We'll talk about mean arterial pressure shortly. When we reach the arterioles, when the blood reaches the arterioles, the pressure has dropped to 50 millimeter of mercury. So about 50 millimeter is dissipated in overcoming the resistance. And then just around that tiny little arterioles, from one end to the other end, the pressure drops to 20 millimeter of mercury. So 30 millimeter of mercury pressure has dropped around just the arterioles. So that is how much resistance it offers. Secondly, it has the controls on it. It has systemic and sympathetic and parasympathetic systems. Sympathetic innervation is present. Parasympathetic innervation is not present, but chemical substances that are parasympathetic can come and act on them, and the arteriolar diameter can change. So remember this, please, that arterioles are the functional sphincters of cardiovascular system, or they are the contributors, primary contributor to total peripheral resistance. So whenever we'll say increased resistance or reduced resistance, we are talking about the arterioles. Finally is the compliance. Compliance is the elasticity of a blood vessel. So let's say if I have a elastic fiber and I put that around the arterial wall, so now this artery has become elastic. Distensibility is called compliance and recoil is called elasticity. It comes from the same one thing, and that is the elastic fiber. Now the compliance is important because as we push the blood volume in a blood vessel, that vessel has to become distensible to accommodate the volume. Then it squeezes that blood to get it out of it. So that is how the pressure is maintained. So of course this is a very important phenomena. Compliance reduces with age and reduces in some pathological conditions like arteriosclerosis or atherosclerosis. Okay, so now let's talk about the pressures. This is a pressure graph here. The systolic pressure is defined as maximum pressure or peak pressure measured in a systemic artery during the left ventricular systole. That is the systolic pressure. In a normal healthy individual, it is about 120 millimeter of mercury. The factors that contribute to the systolic blood pressure, the most important, the major factor that contributes to it is the stroke volume. Higher the stroke volume, higher the systemic pressure. Why? Because the greater amount of blood will cause greater pressure, lateral pressure in the walls, and because the walls are distensible, they would squeeze back and that would create pressure. So stroke volume causes systolic pressure. Heart rate. Reduced heart rate, now this is funny, reduced heart rate causes increased systolic pressure. Barring that there is any pathological condition, this is physiological phenomena. So what happens is that when the heart rate reduces, heart has a longer time period to get the blood, so it fills more. When the ventricles fill more, the stroke volume increases, and we know that when the stroke volume increases, then the systolic pressure would increase. Compliance. Compliance, as we just talked, it is a distensibility. So if, let's say, this blood vessel is not distensible, we are trying to push blood in it, and blood is struggling to get into this, and the volume is great. What would happen is that systolic pressure would be measured as high. On the other hand, because the vessel is not recoiling, when the blood gets out, the smaller amount of volume of blood that is left, the vessel is not going to squeeze hard, so diastolic pressure would be reduced. So please remember, reduced compliance increases systolic and reduces diastolic pressure. Diastolic pressure. The definition of the diastolic pressure, this is this lower line here. Diastolic pressure is the minimum pressure or the lowest pressure measured in a systemic artery during the diastole of a ventricle, left ventricle. Normally measured at about 80 millimeter of mercury. The major contributor to this is total peripheral resistance. Systolic major contributor, stroke volume. Diastolic major contributor, total peripheral resistance. Why? Because it is a peripheral resistance that is resisting the flow of the blood, and the longer the blood and the more blood stays in the vessels, the more pressure there will be. If there is no peripheral resistance and all blood gets out of the blood vessel, there will be no pressure. So if you reduce the peripheral resistance, more blood can escape, then the diastolic or the minimum pressure measured will be low. So total peripheral resistance, you reduce the resistance, you would reduce the diastolic pressure. You increase the resistance, you would increase the diastolic pressure. Pulse pressure. Pulse pressure is the difference between systolic and diastolic pressure. That is, pulse pressure equals systolic pressure minus the diastolic pressure. It's a derived number. It is called to become wide or narrow in various conditions. For example, look at it. Compliance is the major factor that changes it. And let's see what happens. When a blood vessel is less compliant, that means when you're trying to push the blood in it, it will not extend. So the systolic pressure would increase because blood is now trying to open up the vessel. So let's say it went from 120 to 140. On the other hand, when the blood has squeezed out, when the blood is going out, the blood vessel is not squeezing hard. So do you think that if it was going to squeeze harder and it would, on a low volume, it would create 80 pressure? Now it is not squeezing. Do we have 80 pressure here? No. We have maybe 60 or 40 or something like that. So what happens is systolic is higher, diastolic is lower, due to which the pulse pressure is high. So 140 minus 60 is 80. So this patient has a pulse pressure of 80. So this is called widening of the pulse pressure, normally because of the reduced compliance, which is because of aging or atherosclerosis or arteriosclerosis. On the other hand, pulse pressure can become narrow. Let's say the stroke volume reduces. So there is not enough blood volume to come and push against the blood vessels. Blood vessel is not extending anyway. So let's say the pressure is 110. The stroke volume is less. Now, when the volume is getting out, let's say the aorta can still squeeze that volume, but little bit. So let's say the lower pressure, diastolic pressure is still 80 and the systolic pressure is 110 because of hemorrhage. Then what would happen is that the pulse pressure is 30. Mean arterial pressure. Mean arterial pressure is the average pressure inside the blood vessels during one cardiac cycle. Average pressure in a blood vessel during one cardiac cycle. The formula for the mean arterial pressure is cardiac output multiplied by total peripheral resistance plus central venous pressure. Now, central venous pressure is negligible. We don't use it. That leaves cardiac output plus total peripheral multiplied by total peripheral resistance. These are the two factors that change the mean arterial pressure. Mean arterial pressure is used instead of systolic pressure to understand if there is enough nourishing pressure across the tissues. Normally, if it is lesser than 60% of the systolic pressure, then we have a problem with the nourishment. Two things to remember here. One, if one of the factors goes up, then other factor has to go down. If cardiac output increases, then the peripheral resistance has to reduce. If the peripheral resistance increases, then the cardiac output has to reduce in physiological scope. If there is a pathology, then they both might increase, they both might reduce, and one of them might increase and the other one may not work. The other thing to remember is that for the mean arterial pressure, the rough formula that you can use with systolic and diastolic pressure to assess it is take the diastolic pressure plus add 1/3 of the pulse pressure. So pulse pressure is this. Normally, if you take 120 minus 80 is 40 pulse pressure in this patient. And let's say diastolic pressure is 80 here. So 80 plus 1/3 of 40 is 13. So that will make it 93 millimeter of mercury. That is the mean arterial pressure. Cool. So thank you very much.